Good evening, all. I am Dr. Karunakar, consultant critical case, Apollo Hospital, Jubilee. I will be talking on transcranial Doppler ultrasonography and optic nerve sheath diameter. So, first of all, we'll talk about the introduction. So, transcranial Doppler is a less expensive, non-invasive tool which provides a rapid and real-time measure of cerebral vascular function. It can assess any changes in the flow velocity, and it can detect vascular stenosis and also detect embolic signals. So it was introduced in 1982 by Salid and colleagues. It's a stethoscope for brain. The principle behind the transcranial Doppler is the change in the frequency of emitted pulse of ultrasound is reflected by red blood cells. It's proportional to the flow velocity. Transcranial Doppler expressed in centimeter per second. It uses frequency of 2 megahertz. So the transcranial Doppler ultrasonography uses Doppler technique. Actually, it used as an indirect measure of CPF. We assume that the constant vessel diameter, unchanged angle of inclination, but it's not possible all times. So there are some factors that may affect the diameter of vessels are arterial carbon dioxide tension, blood pressure, anesthetic agents, vasoactive drugs, and thickness of the skull. And also some factors may affect the accuracy of low velocity measurements like conditions, intracranial lesions, increased ICP condition, and cerebral vasospasm. The human skull has 4 windows to insinuating intracranial vasculature. So in that, we first of all will see transtemporal area window. You can see the mid-cerebral artery and anterior cerebral artery and PCA cerebral artery. So next is suboccipital. Suboccipital, you can see basilar artery and vertebral artery. In the transorbital, you can see ophthalmic artery and carotid chiffon. Lastly, you can see in transforaminal window through the foraminal window, you can see extracranial internal carotid artery. So ACA can see at the depth of the 70 mm, MCA can see at the depth of around 50 mm, PCA can see at a depth of 65 mm. This is the normal spectral waveform. According to the systolic diastolic phase of the heart, the aortic wall closes, then it's open, the heart contracts, peak systolic velocity is measured. Then aortic wall is closed by the dicrotic notch, the endostolic velocity is measured. The interval from phase 1 to phase 1 is referred to as systolic acceleration, that is called upstroke. Then phase 2, phase 3, phase 4 is the different. The interval is the diastolic phase that reflects resistance from the artery of the increased periphery. So the figure shows ICA verification into the ACA and MCA. You can see at a depth of 57 mm. That M1 segment of MCA can see at the depth of 50 mm. PCA can identify and also distinguish from the MCA because of a low flow velocity, can identify at the depth of 57 mm. ACA first segment can identify at the depth of 70 mm. There is a normal spectral waveform and there is terminology. The peak systolic velocity is the highest first peak of the TCD waveform from each cardiac cycle. So end-diastolic velocity is it lies between 20 to 50% of peak systolic velocity. Next is the mean flow velocity. The mean flow velocity is calculated as end-diastolic velocity plus 1/3 of the difference between peak systolic velocity and end-diastolic velocity. So there are 2 derived indices have been to quantify the pulsatility. So there is a Gosling pulse rate index. The Gosling pulse rate index is difference between peak flow velocity and end-diastolic volume divided by peak flow volume. So next is the resistant index. Resistant index is the difference between systolic and diastolic divided by peak flow or systolic. There are some conditions. So flow velocity may decrease or increase in the flow may decrease or it increase. So the vasospasm, hyperemia, increased PaCO2, intracranial artery stenosis. With increasing age, there may be increase in flow velocity in the Doppler. So flow velocity may decrease in the hypotension, decrease cerebral blood flow, brain death, and raised ICP, decrease PaCO2, and hypothermia. Pulsatility index and resistant index. So resistant and pulsatility index may increase in conditions where raised ICP, hydrocephalus, and traumatic brain injury, intracerebral hemorrhage, stroke, and brain death. So whereas decrease whereas at wavy formation, vasospasm can decrease the index. So what there is some clinical application of pulsatility index. So if your pulsatility index more than 1.5 may indicate the elevated ICP, and also asymmetry in pulsatility index value between left and right hemisphere may give rise to asymmetry cerebral hemodynamics. There are some pitfalls and trouble spots. So the TCD may require high degree of operator dependency. There may be some variations, incomplete circulatory. So you can't do you can't identify the vessels. So there are some absent or some small temporal windows. Sometimes cannot identify the best temporal window also. And lastly, the improper Doppler settings like too low, too high gain, or low power mode can cause pitfalls. So now, all people will not have all people will not have classical anatomy, but so there are some anatomic variants. There are some anatomic variants. 80 to 20% people will have classes circulatory hypoplasia of one or both PCOMs. So 50 to 20% people will have hypoplasia of P1. 13% will have hypoplasia of ACOM. 9 to 40% people will have duplicate or triplicate ACOM. So these variants cannot sometimes may not identify the vessels. So next is clinical practice, Transcranial Doppler in clinical practice. So TCD can assess the cerebrovascular reserve and detect shunt malfunction and integrity of the cerebral autoregulation. It will detect the cerebral ischemia during pre-cross clamping of the carotid artery. And also it will detect the embolic phenomena pre-operative and post-operative conditions. If during pre-clamping time, if flow velocity is more than 40, that means there is no ischemia. If it is less than 15%, that means that severe patient will have severe cerebral ischemia. So you can see the figure shows the before clamping, after clamping. Before clamping, the flow velocity will decrease, will know that after clamping, after end of procedure, flow velocity increase. That means the procedure is successful. Sometimes if a post-operative drop in flow velocity can indicate that post-operative occlusion of infiltrated carotid artery. That means the patients may require re-exploration. Next, so TCD translate Doppler can do in subarachnoid measure, but is unreliable as a measure of CBF in a patient with SAH because change in the vessel diameter. But it's a valuable for diagnosing vasospasm before the onset of clinical symptoms. There is a ratio that is called Lindegaard ratio. The flow velocity ratio between MCA and ACA, if it is more than 3, is called signifies that vasospasm. According to degree of ratio between MCA and ICA, for Lindegaard ratio more than 3, that is called mild vasospasm. If it is more than 6, that is severe vasospasm, severe vasospasm. So the sensitivity of the anti-circulation was 73 and the specificity of 80%, specificity is 80%. So when the drop in flow velocity of MCA does not exceed 65% of the basal value, ICU occlusion is generally well tolerated. So next clinical application, severe stenosis, severe intracranial stenosis. So in severe cranial, you can that figure like figure shows the here there is increased systolic and decreased low diastolic velocities, and you can see high peak and high mean velocities. High mean velocities. These velocities, abnormal waveforms can see in the intracranial stenosis. So this is a M mode. This pulsatile window. In pulsatile window, there is a increased mean velocity in MCA that consistent with a mild to moderate vasospasm. Next, you can see the acute stroke. This is the left MCA occlusion. In the Doppler window, you can see the left MCA occlusion. The white small arrows showing no flow in the diastole. When you see in the angiogram, there is a black arrows. It will shows the arterial occlusion. So we can correlate with a transcranial Doppler with the angiogram. Next, the thrombolysis and brain ischemia classification. They did examine Andrew et al. They did examination acutely on the day 2. We were treated with a IVTPA in a patient with stroke patients. So the TB flow like a thrombolysis and brain ischemia, Doppler residual flow can graded as a 0 to normal. The classification correlate with the initial stroke severity and clinical recovery mortality. So a flow grade improvement correlated with the clinical improvement. So they graded as a 0 to normal. Grade 0, there is no flow. Absent flow signals are identified. The grade 1 is a minimal flow. You can see systolic spikes of the velocity, but there is no diastolic flow. So blunted, grade 2 is a blunted. The flattened systolic flow, you can see flattened systolic flow acceleration. Then you can see normal. Grade 5 is a normal flow. You can see normal waveform like peak systolic and end diastolic volume. Next is cerebral. You can identify cerebral circulatory arrest by transcranial Doppler. There will be the criteria will be should be oscillating waveform, small systolic spikes. So upper panels, upper row shows there is a systolic peaks and increase systolics, but there is no reverse flow. That means the increasing ICP. Next, you can see the lower panel shows. So lower panel shows biphasic flow or oscillating flow. Then small systolic spikes, but there is no lower panel shows reverse. There is no reverse flow, but the asymmetry will be both forward and reverse flow is not there. If the brain death can be cerebral circulatory arrest can be confirmed if the both flow and reverse flow is equal. So the picture shows the figure shows that diastolic flow reversal and biphasic oscillating flow. Oscillating flow is evidence by 0 net flow, that is almost confirmed the brain death. And you can see blunted diastolic blunting. Diastoling, you can see the diastolic and evidence of raised ICP. Next is optic nerve sheath diameter. Optic nerve diameter ultrasound has been shown to correlate with the increased ICP. It's a non-invasive, radiation-free bedside tool to assess elevated ICP. Indications are traumatic and non-traumatic brain injury, intracranial hemorrhages, DKA, metabolic disorders, shunts, hydrocephalus, PP shunt, hydrocephalus, and hypoxic injury. So the figure shows that D1 denotes distance from the optic retina from the retina to the optic nerve sheath diameter measurement, that is 3 mm. D2 denotes they measure the optic nerve sheath diameter to from retina. The second panel shows the corresponding image shown labeling as I for direct comparison with the clinical image. So optic nerve sonography is performed with a high frequency linear transducer. It uses more than 7.5 megahertz. VNST measurements performed 3 mm posterior to the papilla base, but in a pediatric patient, the sheath may be much more proximal than adults. The advantage of focus of INSD are low cost, short investigation time, repeatability, bedside availability, radiation free. There are some contraindications, ultrasound, ocular trauma, diseases associated with the abnormal intraocular pressure, optic nerve atrophy, inflammatory lesions of the brain. So you can see the normal optic nerve sheath diameter will be 3.8. Like if the optic nerve sheath diameter more than 5 mm, that signifies the raised ICP. If not controlled, if not controlled with the ICP control measures, if it is a diameter, it will be more than 60 mm after 24 hours of management. That means that the poor patient will have poor outcome. Thank you.